Welcome to the Hospital Medicine Unplugged podcast. Today, we are undertaking a critical deep dive into a common, yet very high-stakes dilemma in inpatient neurology, the acute presentation of facial weakness. Our listeners shared sources that really emphasize the profound consequences of misdiagnosis. You're weighing missing a time-sensitive stroke versus initiating a totally unnecessary resource-intensive stroke protocol for a peripheral nerve palsy. Our mission today is to clearly define the clinical, anatomical, and management differences between Bell's palsy and stroke-related facial weakness, tailored specifically for you, the clinician working with the hospitalized patient population.
That's absolutely right. And this distinction is, it's certainly not just academic. It dictates whether a patient gets potentially life-saving reperfusion therapy or, on the other hand, appropriate steroid treatment and eye protection. What's fascinating here, and what really changes our practice, is how much the pretest probability of alternative diagnoses changes when a patient is already hospitalized. It means our threshold for an advanced workup has to adjust substantially. So we need to focus intensely on the key distinguishing features, the diagnostic red flags, and of course the critical time targets mandated by guidelines for inpatient stroke management. The consequences of getting this wrong are just so high.
Okay, let's unpack this. Before we can even consider diagnostics, we have to go back to the foundational neuroanatomy. The moment we walk into the patient's room, our first job is to localize the lesion. And that fundamental difference between a central and a peripheral cause comes down to upper motor neuron versus lower motor neuron innervation, specifically of the face.
Exactly. The key, as you say, is the forehead. And understanding the anatomy makes your clinical exam incredibly sensitive. It's really the single most important differentiating factor we have at the bedside. So Bell's palsy represents a lower motor neuron, or peripheral, seventh cranial nerve dysfunction. This means the actual lesion, the problem, occurs after the nerve has already left the brainstem. It's in the peripheral nerve itself.
And because it's a peripheral lesion affecting the nerve trunk distal to its origin.
Precisely. Because it affects the entire ipsilateral nerve trunk, it impacts all the facial muscles on that one side equally. This includes the muscles of the lower face, the mouth and the cheek, and the muscles of the upper face. So the orbicularis oculi for eye closure, and the frontalis for wrinkling the brow. The patient will have a complete inability to wrinkle the forehead on the affected side. It's complete ipsilateral paralysis.
Let's contrast that immediately with the stroke, which is a central upper motor neuron lesion.
Right. Stroke, on the other hand, is generally an upper motor neuron or central lesion. This typically affects areas like the motor cortex, the internal capsule, or even the brainstem before the impulse ever reaches the facial nucleus down in the pons. And the crucial anatomical difference here lies in the peculiar bilateral cortical innervation of the upper facial muscles.
Okay, explain that bilateral innervation, because that is the physiological reason why forehead sparing happens in a stroke. It's such an elegant point.
It really is. The motor pathway that controls your upper face, so specifically the frontalis and orbicularis oculi, it actually receives input from motor pathways that originate in both the left and the right cerebral hemispheres. It's like a built-in redundancy, a protective mechanism, if you will. So if an ischemic or hemorrhagic stroke wipes out the motor command pathway descending from one side of the brain.
Central lesion.
Yes, the central lesion. The upper face still receives enough compensatory motor input from the unaffected side of the brain to function. And the result? The patient retains the ability to wrinkle their forehead. They can often close their eye on the affected side, although it might be a little bit weaker. The noticeable weakness is concentrated almost exclusively in the lower face. The mouth, the nasolabial fold, that inability to smile or show their teeth.
That makes the exam so elegant. If they can wrinkle their forehead, the problem is central, most likely a stroke. If they cannot wrinkle their forehead, the problem is peripheral, suggesting Bell's palsy or another LMN process.
Exactly. But to fully understand Bell's palsy, we should probably delve into the specific pathophysiology for a moment. It helps to understand why it's a lower motor neuron issue that's confined to that peripheral nerve. It's defined as an idiopathic acute LMN facial nerve palsy, but, the root cause isn't really a mystery anymore. It's often viral reactivation.
That's a key piece of information. Which viral agent are we talking about primarily?
Well, research strongly implicates viral reactivation, particularly herpes simplex virus type 1 or HSV1 as a leading mechanism. The virus reactivates within the geniculate ganglion, which is a cluster of sensory neurons situated right along the facial nerve pathway. And this reactivation causes significant inflammation and subsequent cytotoxic edema swelling of the facial nerve itself.
And this is where the anatomy of the skull becomes a major problem, right? The nerve is trapped.
It is absolutely trapped. As the facial nerve courses through the skull, it passes through the facial canal, a very narrow, non-expandable bony structure within the temporal bone. This anatomical constraint, that narrow tunnel, makes the nerve exquisitely vulnerable. So when the nerve swells due to inflammation, it leads to mechanical compression, and the subsequent decrease in blood flow causes an inflammatory ischemic neuropathy. That compression is what results in the acute element dysfunction. It's literally a strangulation of the nerve inside a bony tunnel.
That's a perfect way to visualize it. A supply chain issue within a very tight tunnel, leading to an ischemic injury of the peripheral nerve itself. Now, contrasting that again with stroke etiology, the cause is a vascular catastrophe impacting the central pathways.
Right. A stroke is a sudden central vascular event. It's typically ischemic, meaning a clot stops blood flow, or sometimes hemorrhagic, where a vessel ruptures. We're looking at lesions affecting the high motor centers, the motor cortex, the corona radiata, the internal capsule, or sometimes deep in the brainstem, specifically pontine strokes, which we'll definitely discuss later because they represent a major pitfall.
Yeah.
Importantly, in our hospitalized population, you must always consider the underlying systemic mechanisms that are driving that stroke risk.
What are the most common mechanisms for inpatient stroke that we need to be vigilant about?
We absolutely need to be vigilant about cardioembolism. Patients who are admitted for other reasons often have undiagnosed or poorly managed atrial fibrillation, or A-flutter, which significantly increases their stroke risk. Recent surgery is another major risk factor due to the prothrombotic state. And we also have to consider the hemodynamic instability that's so common in critical care or perioperative settings. This can lead to hypotension-related watershed infarcts, particularly in patients who have pre-existing vascular disease. It's a lesion interrupting that central motor command, and it's often preventable or treatable if we catch it fast enough.
Moving beyond the anatomy, let's define the presentation timelines, because the speed of onset is another critical differentiator that helps us triage. Bell's palsy has a relatively acute but not instantaneous onset.
Correct. Bell's palsy symptoms develop over a period of time, typically reaching their maximum severity or peaking within 72 hours, so over 1 to 3 days. It's crucial to ask the patient or their family not just when it started, but how quickly it reached its current state. Did it get progressively worse over 48 hours, or did it happen, in a flash? Bell's palsy also often involves a brief prodrome or associated features that stem from dysfunction of other nerve fibers that travel alongside the seventh cranial nerve.
What specific associated features should we be asking about?
The associated features can include post-auricular pain, which can sometimes be quite severe and actually precede the paralysis. Patients may experience dysgeusia and altered taste perception, specifically on the anterior two-thirds of the tongue, and hyperacusis, which is an increased sensitivity to sound due to paralysis of the stapedius muscle in the middle ear. They might also complain of decreased lacrimation or a dry eye, but, and this is the critical caveat, Bell's palsy must present as isolated facial paralysis. If you find any other focal neurologic abnormalities, that isolation is broken and you have to assume a central cause.
And the stroke timeline is the sharp contrast to that 72-hour window.
Stroke is almost always sudden. The onset occurs within seconds to minutes. It represents an abrupt loss of blood flow or a rupture event. What's critically important for you as the hospitalist is to note any case where the onset is gradual, maybe over more than 72 hours, or if the course is prolonged, extending beyond 3 months. That temporal pattern in any facial palsy should immediately be considered a massive red flag.
Why does a gradual onset, one that exceeds 3 days, change the differential so dramatically?
That kind of time course strongly suggests a non-idiopathic, structural, or infiltrative process, rather than the acute inflammatory edema we see in Bell's palsy. At that point, you're hunting for things like a neoplasm, a tumor compressing the nerve, or a chronic infection. In the Bell's palsy literature, if the palsy is progressive past that first 2 weeks, or if there's a complete absence of any recovery past 3 months, the likelihood of a structural cause jumps significantly, mandating an advanced workup.
That transition leads us perfectly into our next point. We cannot treat a hospitalized patient with facial weakness the same way we would treat a healthy person in an outpatient clinic. We need to focus on the high-risk populations and the red flags we must recognize in the inpatient setting.
Absolutely. What's fascinating here, and what changes our clinical approach fundamentally, is the shift in epidemiology. While Bell's palsy accounts for 60 to 75% of facial paralysis in the general population, once a patient is admitted to the hospital, that proportion shrinks. In hospitalized cohorts, the prevalence of non-idiopathic, serious causes is substantially higher. Our sources show this figure is often around 25 to 30% of cases. That means 1 in every 3 or 4 patients you evaluate with acute facial weakness might have something potentially life-threatening or oncologic, not just benign Bell's palsy.
That significantly raises our pretest probability for malignancy, infection, or central pathology. So let's detail the specific high-risk contexts we see in the hospital, starting with malignancy.
Malignancy represents a highly dangerous mimic, particularly in patients with a history of cancer. We need to look very closely at the patient's past medical history. Specific cancers show extraordinarily high associations with non-idiopathic facial paralysis. For example, a history of skin cancer or precancerous lesions gives an odds ratio of 7.3 for a non-idiopathic facial paralysis.
Okay, let's stop and unpack that. An odds ratio of 7.3. What does that mean for the hospitalist in practical terms?
It means the probability of that facial paralysis being caused by a skin cancer invasion rather than Bell's palsy is over 7 times higher than the general population. It's a huge multiplier. And it's even more striking with salivary gland cancer, which carries an odds ratio of 41.1.
41. That's massive.
It's massive. It essentially means if you see facial weakness in a patient with a history of salivary gland malignancy, you must operate on the assumption it's cancer until proven otherwise.
And crucially, malignant facial paralysis differs not just in its cause, but in its clinical evolution, right?
Yes, malignant causes are often characterized by a gradual onset and progression, unlike that typical acute peak of Bell's palsy. Studies show that 57.4% of patients with a neoplastic cause had a gradual onset, compared to only 10.3% of those with idiopathic causes. This gradual progressive worsening, especially if it continues past 2 weeks and is unresponsive to standard steroids, is a major signal that a structural or infiltrative tumor process is invading the nerve sheath or the parotid gland.
Beyond malignancy, we have infectious and inflammatory causes that necessitate specific non-steroid treatment. This is particularly relevant in the immunocompromised or critically ill patient.
We must highlight infectious causes requiring specialized treatment. Ramsay-Hunt syndrome, which is caused by varicella-zoster virus reactivation, often presents with vesicles in the ear canal or on the soft palate. Lyme neuroborreliosis, depending on the patient's endemic area exposure, is another critical consideration. Other CNS infections, including those we see in immunocompromised hosts, can also manifest this way. This is precisely why cerebrospinal fluid analysis can be so valuable in the inpatient setting.
And our sources confirm high diagnostic yields from CSF analysis for those specific conditions.
They do. CSF analysis has demonstrated 85% sensitivity for Ramsay-Hunt syndrome and a remarkable 100% sensitivity for Lyme neuroborreliosis when it's clinically suspected. So if the clinical picture suggests infection or inflammation, especially if it's bilateral or if the patient has a fever, meningismus, or other signs of meningeal involvement, a lumbar puncture can be diagnostic and immediately guide specific antiviral or antibiotic therapy.
And finally, we have to acknowledge that the inpatient environment itself elevates the stroke risk, especially in postoperative and critical care patients who are really the core of hospital medicine.
Postoperative and critical care patients face unique vulnerabilities. They're at elevated stroke risk, often from cardioembolism, as they frequently have high rates of aflutter or new-onset atrial fibrillation after surgery. There's also the significant risk of hypotension-related watershed infarcts, which are particularly common in those with critical illness, sepsis, or perioperative hemodynamic instability. Their blood pressure is often labile and can swing outside of those autoregulation zones.
The challenge in the ICU is that sedation or positioning can mask or even mimic these deficits, making the initial recognition much, much harder.
Absolutely. Positioning during a prolonged surgery can cause compression palsies that mimic Bell's palsy. But more dangerously, sedation or altered mental status in the ICU can hide subtle central deficits. An isolated facial weakness might be the only visible sign of a devastating brainstem stroke if the patient is otherwise obtunded. This forces us to maintain a much higher index of suspicion for stroke in the critical care setting, even if the clinical exam is incomplete.
Here's where it gets really compelling. We've established this higher baseline risk in the hospital. What findings, beyond the classic forehead sparing, absolutely require us to look beyond Bell's palsy and activate a full stroke workup immediately?
Right. We must always maintain a lower threshold for activating a stroke protocol in hospitalized patients. So beyond forehead sparing, which is your primary UMN differentiator, there are critical red flags that mandate immediate neuroimaging. First, Bilateral facial involvement. This is almost never Bell's palsy, which is typically unilateral. Bilateral palsy suggests generalized processes like Guillain-Barré syndrome, sarcoidosis, Lyme disease, or HIV-related neuropathy, all of which require urgent, very distinct treatments.
And the second major red flag.
Second, any other neurologic abnormalities. If you find any concomitant sign limb weakness or hemiparesis, speech disturbance like dysarthria or aphasia, visual changes, gait ataxia, or abnormal extraocular movements, alongside the facial weakness, the lesion is central until proven otherwise. The facial weakness is no longer isolated to the seventh nerve distribution. It's part of a larger, multi-track central syndrome.
What about symptoms related specifically to the ear or balance?
Third, hearing loss, tinnitus, or vertigo. These suggest involvement of cranial nerve 8th, the vestibulocochlear nerve, or central auditory pathways. This often points to a brainstem pathology or potentially structural lesions like a vestibular schwannoma. The facial nerve and the vestibulocochlear nerve travel very closely together. Any accompanying CN8 symptom should make you highly suspicious. And fourth, ipsilateral recurrence of facial palsy. While it's rare, recurrence raises immediate concern for an underlying mass, requiring dedicated neuroimaging.
We have to discuss the crucial exception: brainstem or pontine strokes. This is a classic diagnostic pitfall because they can defy the forehead sparing rule and mimic a peripheral lower motor neuron pattern, causing complete ipsilateral facial paralysis.
This is truly a critical point that can confound even the most experienced hospitalist. A stroke that involves the facial nucleus itself, or the facial fascicle, that bundle of nerve fibers as it traverses the pons in the brainstem, can cause complete ipsilateral lower motor neuron paralysis. Clinically, on the face alone, it's indistinguishable from Bell's palsy. However, these are almost invariably accompanied by other signs due to the extremely dense concentration of fiber tracts and nuclei in that tiny area of the brainstem.
So if you see complete LMN facial paralysis, but you have a high clinical suspicion for a brainstem stroke, what specific signs are you hunting for in your comprehensive cranial nerve exam to localize the pathology?
You have to look for the neighbors. For example, look for an ipsilateral abducens nerve palsy, that's cranial nerve VS, which causes difficulty looking horizontally. Or look for ipsilateral trigeminal sensory loss, which is CNV. The lesion often affects the motor tracts descending below that level, so you might also find contralateral hemiparesis, or hemisensory loss. This combination of ipsilateral cranial nerve deficits and contralateral long tract signs is known as a cross sign, or alternating hemiplegia, and it is pathognomonic for a brainstem lesion.
That immediately localizes it above the peripheral nerve to the central nervous system.
Exactly. Isolated peripheral facial weakness strongly favors Bell's palsy. Any concomitant deficit, especially a long tract sign, another cranial nerve finding, or a cross sign, immediately mandates neuroimaging to exclude a devastating brainstem pathology. The key is to expand your exam beyond just the face.
This emphasis on speed and comprehensive examination brings us directly to the rapid inpatient evaluation protocols. For the hospitalist, time is brain, especially when stroke is a possibility. The American Heart Association and American Stroke Association set very aggressive time targets for in-hospital stroke.
They do, and they are aggressive because in-hospital strokes are notoriously delayed. We have to commit these to memory and empower our teams to meet them. Symptom discovery to stroke alert activation should be less than 5 minutes. Time to neurological expertise, less than 10 minutes. Time to CT or MRI, less than 25 minutes. And time to treatment initiation, less than 60 minutes. These are targets that demand institutional standardization.
That's a monumental challenge given that the patient is often already admitted and potentially on a low acuity floor. What is the observed reality regarding these delays, and what's the biggest functional bottleneck?
The challenge is truly staggering. Studies have consistently shown that in-hospital strokes face substantial delays. We're talking, on average, 4.5 hours from recognition to imaging versus 1.2 hours in the emergency department. The system is naturally geared for rapid response in the ED, but that recognition loop on the floor is often much slower. It involves the nurse, the resident, the attending, and then the stroke team notification. The biggest bottleneck is often the initial recognition by non-neurology staff and the delay in activating the alert system.
So what concrete steps can the hospitalist take to close that 4.5-hour gap and get closer to the 5-minute activation target?
We need to standardize protocols and empower our frontline staff. The hospitalist should insist on rapid response ordering sets for acute neurological changes. Furthermore, you have to immediately determine the time last known well. This time is essential for deciding thrombolysis eligibility, which has a strict 4.5-hour window. For a patient who is postoperative, who might have been sleeping or sedated, the last known well time might be the time of anesthesia induction. This can drastically narrow the therapeutic window and requires intense forensic work in the chart immediately.
Let's detail the initial rapid assessment steps that need to happen the instant the stroke alert is called for acute facial weakness.
The initial steps are non-negotiable standards for any acute neurological event. You stabilize airway, breathing, and circulation. Your ABCs, you check vital signs, and critically, you measure immediate blood glucose. We must rule out hypoglycemia as a stroke mimic. Glucose levels below 60 can cause acute mental status changes or focal deficits that fully resolve as soon as you give them sugar.
We then move to the standardized assessment scale, the National Institutes of Health Stroke Scale, or NIHSS. We should discuss its limitations, especially for the nuanced presentations we're talking about here.
The NIHSS is standard for quantifying stroke severity, but clinicians have to recognize its blind spots. It often results in low scores, maybe 2 to 4 points, for disabling brainstem or cerebellar strokes, or for an isolated facial palsy. These low scores can provide a false sense of security about the stroke's overall severity, yet these posterior circulation strokes can be profoundly disabling. They can lead to severe vertigo or ataxia, or even be life-threatening due to their proximity to cardiorespiratory centers. Therefore, if your clinical judgment strongly suggests a brainstem event, you have to remain highly suspicious, even if the NIHSS score is low.
The immediate imaging required is time-sensitive, and the guidelines prioritize speed over ultimate detail, at least initially.
Yes. The initial imaging required is a non-contrast CT head, and the target is to complete it within 25 minutes of symptom discovery. The primary purpose of that CT is purely to rule out intracranial hemorrhage. It's the gatekeeper. If there's no hemorrhage and your glucose is normal, you are on the clock for intravenous thrombolysis. Nothing else is absolutely necessary before considering that intravenous agent.
But the CT has well-known limitations in detecting acute ischemia, especially early on.
That is the necessary caveat. While CT is fast, is readily available, and it's excellent for ruling out a bleed, an MRI with DWI diffusion-weighted imaging is truly the gold standard for acute ischemic stroke. It offers high sensitivity for detecting even small or subtle infarcts, particularly those hidden in the brainstem. Non-contrast CT is the initial standard to rapidly triage for thrombolysis, but advanced imaging, which includes CT or MRI with vascular studies like angiography, is absolutely necessary to guide complex reperfusion decisions, such as whether mechanical thrombectomy is feasible.
This systematic approach allows us to manage the immediate threat of a stroke. But let's circle back to the patient whose initial assessment suggests Bell's palsy, yet they have those high-risk inpatient features, a malignancy history, immunocompromised status, or an atypical progression. This leads us to the targeted workup necessary for non-idiopathic facial palsy.
This is where we operationalize that shift in pretest probability. Standard Bell's palsy in a healthy outpatient typically doesn't require imaging. But for our inpatients, especially those presenting with any red flag, we need a significantly lower threshold for advanced workup. We must protect against the anchoring bias of just calling everything Bell's palsy.
So when does a peripheral palsy mandate advanced imaging, specifically an MRI with contrast, which is superior for soft tissue and nerve visualization?
Imaging is mandatory when the presentation deviates from the classic, isolated, acute peripheral palsy. Specific indications include no recovery at 3 to 6 weeks, or if other cranial nerve deficits develop later in the course. Also, if facial twitching or spasm preceded the paralysis, a phenomenon called facial fasciculation, this is highly suggestive of irritation from a mass or tumor, as the tumor infiltrates the nerve sheath. Recurrent ipsilateral paralysis is another huge red flag for a tumor, and critically, a history of malignancy, particularly skin or salivary gland cancer, given the high odds ratios we discussed earlier.
And why MRI with contrast over just a plain CT?
The MRI with contrast allows for visualization of the nerve structure itself and any potentially infiltrating mass. It has high sensitivity, up to 88% for diagnosing neoplastic causes and 83% for autogenic processes. However, we have to introduce a significant caveat here, which is a common imaging pitfall. We must be careful not to confuse the benign enhancement often seen along the involved facial nerve, especially around the geniculate ganglion in acute Bell's palsy with a small tumor.
How do clinicians differentiate between that benign inflammatory enhancement and true neoplastic involvement on imaging?
This is where clinical context is paramount. Bell's palsy nerve enhancement is usually smooth, linear, and restricted to the segment of the nerve within the temporal bone. Neoplastic enhancement, conversely, is often nodular, irregular, and may be associated with bony erosion or involvement of surrounding structures, like the parotid gland. If the clinical history is a sudden onset, even with enhancement, it's still likely Bell's palsy. If the history is gradual and progressive, that enhancement is treated as high risk.
This raises an important question. When do we need a lumbar puncture and cerebrospinal fluid analysis? This is an invasive procedure we typically reserve for serious diagnostic dilemmas.
CSF analysis is exceptionally valuable in the hospitalized setting, especially when systemic or inflammatory etiologies are suspected, which are more common in this cohort. We use it when the differential includes infections like varicella-zoster virus, which causes Ramsay-Hunt, or Lyme neuroborreliosis, or primary central nervous system inflammatory conditions like sarcoidosis or Guillain-Barré syndrome.
What are the primary indications that should prompt us to perform a lumbar puncture?
The indications include bilateral facial involvement, which strongly suggests a diffuse inflammatory neuropathy, like Guillain-Barré syndrome, where you'd expect albuminocytologic dissociation high protein with a normal white blood cell count. We also need it if we have a strong clinical suspicion for a central nervous system infection like meningitis or encephalitis, or if we're managing an immunocompromised patient with an atypical presentation where opportunistic infections are a primary concern. The high sensitivity data for Ramsay-Hunt and Lyme really confirm the diagnostic utility here.
Now that we've covered the diagnostic pathways for both central and peripheral lesions, let's pivot to evidence-based management, starting with Bell's palsy. Steroids are the absolute cornerstone here, but we need to discuss the nuances in the inpatient setting.
They are non-negotiable, and time is of the essence. Oral corticosteroids are the first-line treatment. The typical regimen is oral prednisone, 50 to 60 milligrams daily for 5 days, followed by a 5-day taper totaling a 10-day course. The initiation must occur within 72 hours of symptom onset for optimal outcome. Research confirms the number needed to treat to achieve complete recovery is approximately 10, and higher cumulative doses, typically 450 milligrams or more over the course, are strongly associated with better recovery rates.
You mentioned inpatient nuance. Administering a high-dose steroid course for 10 days sounds simple, but for our admitted patients, especially those with brittle diabetes, a severe underlying infection, or a history of psychosis, the risk profile changes dramatically. How do we approach necessary steroid therapy in a high-risk comorbid patient?
That is a critical consideration for the hospitalist. For patients with poorly controlled diabetes, we have to proactively increase insulin dosing and monitor blood glucose levels intensely, often needing to double the frequency of checks and adjust basal and bolus insulin to mitigate the steroid-induced hyperglycemia. For patients with active severe infections or uncontrolled sepsis, the steroids may need to be held or deferred until the infection is under control, as the immunosuppression risk outweighs the potential benefit for facial nerve recovery. In these complex scenarios, the decision to treat has to be highly individualized.
Let's clarify the often confusing role of antivirals. Do we always combine them with steroids?
The evidence here is highly nuanced. Antivirals alone, such as valacyclovir or acyclovir, have been shown to be ineffective and should not be recommended as monotherapy. However, combination therapy antivirals plus steroids may provide a modest, albeit controversial, benefit. The American Academy of Neurology rates this evidence as level C, suggesting a modest efficacy at best.
What is the primary benefit we're seeking when we add the antiviral?
We're primarily seeking to reduce long-term sequelae like synkinesis, which is that unintended co-contraction of facial muscles. The number needed to treat to prevent synkinesis is around 12. So for patients presenting with severe paralysis, typically a House-Brackman grade 4 or higher, or those with significant pain or vesicles, suggesting Ramsay-Hunt, we often consider adding valacyclovir 1 gram 3 times daily for 7 days, or acyclovir 400 milligrams 5 times daily for 10 days, in combination with the steroids. The benefit is marginal for recovery, but potentially meaningful for that long-term cosmetic outcome.
Regardless of the medical management plan, there is one supportive measure that is absolutely critical in the inpatient setting for Bell's palsy, and that is aggressive, meticulous eye protection.
This is non-negotiable. Preventing corneal injury is paramount. Because of lagophthalmos, the incomplete eyelid closure, and often decreased tear production, the cornea is exposed and highly vulnerable to drying and abrasion. The supportive measures must be standardized. Artificial tears or lubricating drops frequently during the day, a thick lubricating ointment, such as dexpanthenol ophthalmic ointment, applied generously at night, and crucially, a nocturnal moisture-retaining eye shield or patch to maintain humidity and prevent abrasion while the patient sleeps.
If we see any signs of corneal injury or inflammation, that's an immediate referral, correct?
Yes. If the patient reports pain, irritation, burning, or blurred vision, or if you note conjunctival injection or signs of keratitis, immediate ophthalmology consultation is required. We must be aggressive in preventing irreversible ocular damage, which can sometimes be the most devastating long-term complication of Bell's palsy.
Now let's look at the alternative pathway. If the Racket assessment and imaging confirm the diagnosis is acute ischemic stroke, we're dealing with a time-sensitive emergency protocol that defines the next 24 hours of care.
If the diagnosis is stroke, we have to follow a strict stepwise algorithm based on the time from onset. For patients presenting within that tight 0 to 6 hour window, the critical decisions revolve around intravenous alteplase eligibility and door eligibility for mechanical thrombectomy for a large vessel occlusion. Moving out to the extended 6 to 24 hour window, treatment is still possible, but it's strictly guided by advanced imaging perfusion studies.
Let's elaborate on those advanced imaging criteria like DAWN or DEFU-SE3 as they relate to that extended window.
These landmark trials demonstrated that we can select patients who may still benefit from thrombectomy out to 24 hours based on imaging that shows a large area of ischemic penumbra. The penumbra is the surrounding tissue that is critically hypoperfused but not yet irreversibly infarcted. The criteria look for a large ratio of ischemic but still salvageable tissue relative to the already infarcted tissue or the core. If you can rescue that penumbra, you significantly improve functional outcome, even in a delayed presentation.
Blood pressure management in this acute ischemic phase is extremely delicate, especially around fibrinolytic therapy.
It is intensely delicate. For patients eligible for intravenous alteplase, the blood pressure must be meticulously controlled and maintained at or below 185 over 110 millimeters of mercury prior to initiation to limit the catastrophic risk of hemorrhagic transformation. Once the immediate thrombolysis decision is passed, we enter a stabilization phase. It's critical to avoid aggressive blood pressure lowering.
Why is intensive control, say, a systolic blood pressure lower than 120 so dangerous in the immediate post-thrombectomy or post-lysis care?
Because of the penumbra. That hypoperfused tissue is highly dependent on perfusion pressure. If you aggressively lower the blood pressure, you risk turning that salvageable ischemic penumbra into irreversibly infarcted tissue. We're trying to balance the risk of hemorrhagic transformation with the risk of extending the infarct size. And in the acute phase, permissive hypertension is often necessary to maintain perfusion to those at-risk areas.
Let's discuss hemorrhagic stroke management, which naturally demands a completely different and arguably more aggressive approach to blood pressure.
What's fascinating here is the evidence supporting rapid, nuanced blood pressure control in hemorrhagic stroke. Unlike ischemia, where we worry about pushing the pressure too low, in hemorrhage, we need to bring it down quickly to minimize ongoing bleeding. Intensive systolic blood pressure lowering to a target of approximately 140 millimeters of mercury, smoothly titrated, has been shown to improve long-term functional outcome.
But there's a sweet spot. Lowering it too far can still be harmful.
Correct. We have to be careful not to push it too far. Reduction below 130 millimeters of mercury may be harmful and should be avoided. The goal is rapid, controlled lowering to prevent hematoma expansion without causing secondary ischemia.
The other immediate priority in hemorrhagic stroke, especially in the hospitalized patient, is the rapid reversal of any existing anticoagulation.
Immediate reversal is critical, and we must have standardized protocols in place that bypass the laboratory and proceed straight to administering reversal agents. For patients on vitamin K antagonists, like warfarin, this preferably involves 4-factor prothrombin complex concentrate, or PCC, combined with intravenous vitamin K. For patients on DOACs, we have to use specific reversal agents, darucizumab for dabigatran, or andexanet alpha for factor Z inhibitors, to stop the bleeding as rapidly as possible. And neurosurgical consultation is immediately required for any patient showing signs of mass effect or neurological deterioration.
That covers the acute management phase for both peripheral and central causes. Now let's look at the expected course and follow-up planning, starting with Bell's palsy recovery. What's the typical prognosis?
The prognosis for Bell's palsy is generally favorable, which is reassuring to convey to the patient. More than 2/3 of patients achieve complete spontaneous recovery. In specific populations, like children and pregnant women, recovery rates approach 90%. The median time for noticeable recovery in studies is around 2.6 months, though full recovery can take up to 6 months.
What are the established factors that predict a more favorable outcome, which we can use to counsel the patient?
Younger age, specifically 20 to 39 years, is associated with better outcomes. as are favorable electromyography results if they're performed. And crucially, as we emphasized, early treatment initiation with corticosteroids is strongly linked to a higher likelihood of complete recovery. Conversely, poor prognostic factors include complete paralysis at presentation, a House-Brackman grade the 6th, and advanced age, typically over 60 years old.
Despite the good recovery rates, a significant minority of patients deal with long-term sequelae that greatly impact their quality of life.
Yes, up to 25 to 40% may experience incomplete recovery. This can lead to residual weakness, uncomfortable contractures, and a highly distressing long-term issue called synkinesis, which affects about 26% of patients at 1 year. Synkinesis is the unintended co-contraction of facial muscles. For example, when the patient smiles, the eye on the affected side closes involuntarily, or when they blink, the corner of the mouth twitches. It's a sign of aberrant nerve regeneration.
What should the hospitalist plan for regarding follow-up and escalation of care if recovery is delayed or incomplete?
The follow-up protocol is key to catching those who failed to recover adequately or those who truly had an alternative diagnosis that was initially missed. If recovery is incomplete at 3 months, or if new or worsening ocular symptoms occur, referral to a facial nerve specialist or ophthalmology is mandatory. Furthermore, if complete paralysis persists after 1 week despite optimal medical treatment, electroneurography should be considered.
What is the goal of that testing?
The testing helps assess the extent of nerve degeneration. If the nerve shows greater than 90% degeneration, meaning the majority of the nerve fibers are no longer conducting, surgical decompression of the facial nerve may be discussed, though the evidence supporting its routine use remains limited and highly specialized. In all cases, early involvement of facial nerve rehabilitation specialists for physical therapy is essential to mitigate synkinesis formation.
Turning to stroke outcomes, prognosis is highly dependent on initial severity and, most importantly, on the speed of reperfusion, which validates the aggressive time targets we discussed.
Absolutely. Stroke prognosis is primarily driven by the initial NIHSS score and the time elapsed before reperfusion is achieved. The data strongly validates time-sensitive interventions. For anterior circulation, large vessel occlusion, functional independence. A modified Rankin scale score of 0 to 2 is achieved in 46.0% of patients who received mechanical thrombectomy, compared to only 26.5% with medical therapy alone. That is a massive difference.
And secondary prevention must be aggressively initiated while the patient is still hospitalized to minimize recurrent events.
Secondary prevention is vital and starts before discharge. The key strategies include identifying the etiology of the stroke. For minor non-cardioembolic stroke, dual antiplatelet therapy aspirin and clopidogrel is typically initiated for 21 to 90 days. We also must initiate oral anticoagulation if the underlying cause is cardioembolic, such as aflutter, ensuring that timing is appropriate relative to the size of the infarct and the bleeding risk.
And what other medical management must be optimized?
High-intensity statin therapy is necessary for virtually all atherosclerotic strokes, regardless of the patient's baseline cholesterol level. And finally, we have to optimize blood pressure, often targeting below 130/80 millimeters of mercury for most patients in the chronic phase, balancing stroke prevention with cardiovascular risk reduction.
Finally, discharge planning involves a crucial decision between rehabilitation settings, and this decision needs to be evidence-based and tailored to the patient's capacity.
Right. The choice between an inpatient rehabilitation facility, or IRF, versus a skilled nursing facility, or SNF, depends entirely on the patient's ability to participate. An IRF is appropriate for medically stable patients who can tolerate and benefit from intensive therapy. That's 3 hours of physical, occupational, and speech therapy daily. This is the gold standard for recovering function. Conversely, an SNF is for patients who can't tolerate that level of intensity or require more focused medical management and lower intensity therapy.
So what does this all mean? The complexity of distinguishing Bell's palsy from stroke in a hospitalized environment demands a systematic, high-acuity approach. We must rely on that fundamental neuroanatomical principle forehead sparing versus involvement, but always maintain a lower threshold for imaging and cerebrospinal fluid analysis, especially in patients with high-risk features like malignancy or immunocompromised states.
If we connect this to the bigger picture, the prevalence of non-idiopathic facial paralysis is significantly higher in our inpatient population. The erroneous use of Bell's palsy to describe all facial paralysis can lead to dangerous cognitive errors like premature closure or anchoring bias. Our responsibility is to challenge that initial assumption, to meticulously look for those red flags, the gradual onset, the associated cranial nerve deficits, or a history of malignancy, and ensure that whether it's a stroke or Bell's palsy, time-sensitive and evidence-based treatment is initiated within those critical windows.
Thank you for joining us for this deep dive.
This raises an important question for you to consider. Given the staggering 4.5-hour average delay in recognizing and imaging in hospital strokes, what specific non-physician-driven protocol changes, such as nurse-initiated CT orders or standardized patient surveillance, can your institution implement to empower frontline staff and dramatically reduce the time between symptom discovery and CT acquisition?